Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. This is a very young 28-year-old woman with stage 3C invasive carcinoma of the left breast, also triple negative ER/PR and HER2 negative, who was started on dose-dense doxorubicin cyclophosphamide. And we want to make sure that we explore the recommendations for chemotherapy, surgical management, and adjuvant radiation. As I mentioned, this is a 28-year-old, of course, well before the age of screening mammography for most people. And so she self-palpated a mass in her left axilla and has an excellent performance status. She's premenopausal and has no significant medical or gynecologic history. Family history consists of a paternal grandmother diagnosed with breast cancer in her late 60s, but otherwise fairly unremarkable. And I believe that we don't have any imaging for this patient, so we'll just summarize that. Her diagnostic mammogram and ultrasound of the left breast demonstrated a 2.5 centimeter mass with left axillary adenopathy, measuring about 3.3 centimeters in greatest diameter. A left biopsy showed invasive high-grade carcinoma with secretory features. ER negative, the PR was very weakly positive, less than 10%, and HER2 negative, the PD-L1 incidentally is pending. She underwent a FNA of the left axillary lymph node, which demonstrated the presence of metastatic, poorly differentiated carcinoma. She then had a PET scan, which showed the hypermetabolic left breast mass with an SUV of 19. Also hypermetabolic extensive left axillary lymphadenopathy, also mildly hypermetabolic right scapula with a discrete lesion on the right scapula. PET scan demonstrated hypermetabolic brain activity and an unusual left myocardium activity. However, subsequent echo and MRI of the head were unremarkable. She has been started on sort of a neoadjuvant approach of doxorubicin and cyclophosphamide. And so we might start out with Dr. Hurvitz. Where would you pick up with this patient moving forward from this point in her care?
So I missed the genetic results. Did I miss that? Did she have genetic testing?
So we have not seen the results of genetic testing, but thank you for raising that point, that would be such an important piece of information for this 28-year-old woman.
Yeah, so I certainly think genetic test results are important here, and would use, of course, taxane as after the 4 cycles of AC are complete, and if it were BRCA positive situation, would entertain adding carboplatin to it. So I'd use docetaxel carboplatin. And again, clinical trials, looking for clinical trials in the adjuvant setting if she has residual disease at the time of surgery. These are patients I follow very closely throughout the neoadjuvant setting. I examine their breast and axilla between each cycle of chemotherapy, and if they're Exam is not obvious. I use imaging as well, usually after the third or fourth round of therapy to see if it's responding.
Didn't she have something in her scapula, though? I don't know if they biopsied it or just by the description there. So she may actually have stage 4.
Right.
They didn't say anything about, they were so busy doing the MR for the brain uptake,
Right.
but I just was wondering if they pursued biopsying that to see if it was real.
To my understanding, there wasn't biopsy. I think the decision was made to just follow that clinically and see if there was any sort of response or resolution or change with the sort of giving the patient the benefit of the doubt with neoadjuvant therapy.
In re-reviewing that, she did have hypermetabolic, and there was a discrete lesion on the right scapula. And absolutely, in a situation like this, a biopsy should be done to prove whether or not the patient already has distant metastases. If she does, PD-L1 testing should be done, and initiation of systemic therapy should be done, keeping in mind that this is now a chronic, incurable illness. My first choice wouldn't be the AC regimen, but would be taxane with or without the immune checkpoint inhibitor. BRCA testing, of course, if she were positive, she'd have PARP inhibitors available. We have the availability of sacituzumab govitecan in the third line, clinical trials as well. So this notion that we should ignore a positive finding if it's indeterminate and not pursue it, treat them with curative intent, take them down the path of very tough chemo, tough surgery, radiation, only to have the disease progress within the next 6 months, I think is not appropriate.
I echo that. A couple more comments too. We have ongoing protocols of using radiation as an oligometastatic disease. And if indeed this was a metastasis, you might, as a collective multidisciplinary group, opt to proceed still with a non-metastatic type of approach, unless obviously there was some availability of new systemic agents, but then also considering ablative radiation to the oligometastases. Even her local regional staging is inconclusive. You call stage 3C on some respects, but we're not clear on the basis of TNM why is it stage 3C disease? Does she have stage N3A on the basis of infraclavicular adenopathy? You have to be very precise because all of these things really affect treatment decisions. Management of locally advanced stage 3, even if you get a pathologic complete response, to me, it crosses the threshold that they definitely need adjuvant radiation. Whereas obviously this lady being so young, you're going to be erring on the side, but some of the previous cases we've discussed where they're elderly people with ER positive disease, if they have stage 2 disease and they get a great response, sometimes the responsiveness can decrease the amount of radiation you give. But if it's clinical stage 3, then you're less apt to do that than stage 2. So it's really important to have a clear sense, as Sarah was saying, of what is the disease before any treatment is given.
Thank you so much for those really important points. And I think, just to summarize, if I might, that we would, in this situation, have favored kind of taking a pause and moving forward with diagnostic evaluation of the scapular lesion, and making sure we had a comprehensive understanding of that, and maybe also perhaps waiting for if that was confirmed to be positive, waiting for the PD-L1 testing. Am I summarizing that adequately, Dr. Hurwitz?
Yes, as well as BRCA testing. And I think Dr. Buchholz's point about oligometastatic disease and the use of radioablation techniques, the SABRE COMET study was exciting study result, in my opinion, the first really in a randomized fashion to show benefit by treating with a radioablative approach. But I think our point is, regardless of whether we ultimately decide if she has metastatic disease, regardless of whether it's ultimately decided that she's going to go forward with breast surgery or radioablation to the oligomets or whatever, we have to understand what we're dealing with to provide all the options to a given patient, because this 28-year-old, if it's a 28-year-old with stage 4 triple negative breast cancer is a dire situation.
Appreciate everyone's insight. This is such a challenging situation for these really young patients. So in the future, when confronted with such a scenario, what we would recommend in summary is comprehensive genetic testing. In addition, we would recommend biopsy of the scapular or bony lesion to ensure that this is or is not a metastatic lesion. If it is metastatic disease, of course, it would change the course of treatment and prognosis for each individual patient in this situation. If in this scenario, the patient was found to have metastatic disease to the scapula, radioablation may be appropriate at that time. If no metastatic disease is found and the patient is found to harbor a germline BRCA mutation, we would recommend treatment with docetaxel and carboplatin, following doxorubicin and cyclophosphamide. If residual disease is found following surgery, we would recommend evaluation for potential clinical trials, given that prognosis is poor. We know for patients with triple negative breast cancer who do not achieve a pathologic complete response with their neoadjuvant therapy, and therefore a clinical trial approach would be preferred. Of course, we want to mention that the patient will require adjuvant radiation therapy.